So tonight's session, we're going to be looking at acute exacerbation of chronic obstructive pulmonary disease, or COPD. So there shouldn't be too much that's new in here. It's a refresher for you guys. As you know, we're running sessions once a month on different topics just to improve our knowledge and to stop skill fade, and an opportunity for you guys to focus on something different. John did last month's, which was looking at paediatrics, which can be found on the training website, and this is my turn. So for those that don't know me, I'm Nikki. I am the Southeast trainer, and hopefully at some point I'll get to meet you all in person. Crossed. Lovely, so let's get started. So the aims and objectives is to have a basic understanding of COPD, and we're going to look specifically at chronic bronchitis and emphysema and how they're going to present and what we should look for when we're trying to recognise those. We're also going to have just a little refresher on anatomy and physiology, so how the respiratory system should work and what happens when it doesn't in the case of COPD. We'll look at knowing the signs and symptoms of an acute exacerbation of COPD. So what are we looking out for and how might a patient present? And then understand the normal oxygen saturations of a COPD patient and why they're different to non-COPD patients. And then look at that all important management as a responder and what we can do until help arrives. So looking at COPD, so just a breakdown first of all of what COPD is. So the clue's in the title with this one, as it is with many of them. So the C is for chronic, so referring to long term and doesn't go away. So patients aren't going to recover from COPD once they have that diagnosis. The O is for obstructive. So that's the narrowing of the airways, which is causing a restriction in their breathing. The P is for pulmonary because it's affecting the lungs, and the D is for disease as it's a medical condition. And I've mentioned it just a moment ago, but COPD is an umbrella term for a group of chronic or slowly progressing respiratory conditions caused by airflow obstruction. And COPD will develop over time, and therefore most patients are at least 35 to 40 when their symptoms begin. That might not be when they get a diagnosis, that can tend to happen later on, but it might be about that age that they start to recognise some of the symptoms. And there are two main conditions which we'll focus on this evening, and that's your chronic bronchitis and emphysema. So looking at the figures, it says that WAST receives up to 50,000 emergency calls per year for respiratory conditions, and a high percentage of those are for exacerbation of COPD. And the World Health Organization defines COPD as lung disease that is characterized by chronic obstruction of lung airflow that interferes with normal breathing and is not fully reversible. So we talked about that anatomy and physiology. So it's important that we understand how the respiratory system should work so we can understand what happens when it's not working properly. So really basic, and I'm not going to go into it, but just having a very quick look, as I'm sure you know, that we breathe in through our nose and mouth, and air goes down the trachea into the bronchus, where it then branches off into the bronchioles, down to the air sacs or the alveoli, where that gas exchange happens. And then there's that little picture there of the alveoli, which, if they're nice and healthy, tend to look like raspberries, is what I tend to think of them as. Lots of nice surface area there, so that gas exchange can happen. So you've got the oxygen going in and the byproduct of cells, that CO2 coming out, and it's exhaled, and the reverse process happens to get rid of that CO2. And hopefully, if normal respiratory function is happening, that's going to happen between 12 and 20 times per minute. So that's what we're hoping is happening. That's what we're looking for with our respiratory system. Then if we look at chronic bronchitis, so excuse me. Chronic bronchitis is an inflammation of the lining of the bronchial tube. So there's a picture there you can see of what a healthy bronchial tube will look like, and then when it's inflamed, it's got that mucus going on. So the bronchial tubes carry air in and out of the lungs, as we've just said, and normally they will have some mucus in them. That's the airways stay lubricated, stops them sticking together, and it helps to remove any anything that's in the air at all. Sorry, let me just make sure my iPad's flashing away when people type. So yeah, so if you're coughing anything out, if you breathe something in, that mucus will help to shift it to bring it back to the top to be expelled from that airway. We look at when somebody has chronic bronchitis, what will happen is there's an inflammation and an irritation of the inside of that bronchial tube, and because of that you get swelling, so there's even less space for that mucus to occupy, and then you have excess mucus, which then with an already narrowed airway is then having even more difficulty. So if we look at the list there, it says the long-term inflammation of the airway is caused by excess mucus and that swelling. Because of that mucus, they usually will have a productive cough. So on a normal day-to-day, that chronic bronchitis patient will be producing mucus when they cough. So do ask questions about their mucus production. So thinking about that productive cough, so do ask if they're producing anything when they cough. Ask them, it sounds quite disgusting, but have a look at it. What's going on there? What does it look like? Is it normal? Is it the same amount for them? Is it the same colour? These people are also usually short of breath at rest. Because of that narrowing of the airway, they will tend to have reduced oxygen coming into the body and therefore will be short of breath even when they're resting. Also, it says here that they're often obese. The reason for that is that because they're short of breath, they find it difficult to do things like exercise, difficult to do things like walking up and down stairs, and therefore tend to have a more sedentary lifestyle and tend to then find difficulty losing weight. Because of that reduced oxygen intake, they also tend to have cyanosis as well. So ask again what's normal for them. Sometimes it might be worth asking somebody else in the room, how do they look to you? Do they look normal for them? Obviously, we're concerned about any cyanosis, but do ask what's normal for them. And if they have this ongoing reduction in oxygen within the body, what they'll tend to have is excess strain on the heart, and that can eventually lead to right-sided heart failure and edema as well. So thinking about things like looking at their ankles, seeing if they've got any swelling of the ankles. Quite often if they've got socks on, just pull the socks down and see if there's a mark where the elastic's been of their socks. If they're happy for you to as well, you can also just push your finger into there and come away and see if it leaves an indentation mark, which we call pitting oedema. See if that's there as well. And the reason you get right-sided heart failure is because you get that backup from the lungs coming back in towards the heart. And because of the excess mucus there and the difficulty shifting that, they tend to be prone to chest infections. So asking a history is really important. Just to note as well, it's not very pleasant, but with the chronic bronchitis patient, they tend to be called blue bloaters. You might have heard that phrase before, just because the fact that they tend to be bigger patients and also because of that cyanosis. With the emphysema patients, they tend to be known as the pink puffers, and we'll go into why now. So emphysema results when the alveoli, so those sacs at the end of the airways, are destroyed, usually by things like cigarette smokes or other chemicals inhaled. This can be industrial. We'll go on to causes later. But those small sacs, which should have, as I said, look like a raspberry, lots of surface area, they get damaged over time. And if you can imagine somebody blowing up a balloon over and over and over again, eventually the balloon will never go back to how it was before it was blown up, and it'll always keep some air in it. And similar situations happening with an emphysema patient, so they find it very difficult to get all of that air out, into the and then out of their lungs when they're breathing. And once those alveoli are damaged, they can't be repaired. They don't repair themselves. So that's it. Once they're damaged, that's very difficult for them to have that gas exchange happen. Very difficult for them to get oxygen in and for them to get rid of the carbon dioxide. So basically they've lost their elasticity at this point, and that causes air to be trapped inside them, as with that balloon. And that's why they have difficulty exhaling. Because of that, what you'll find is patients quite often breathe through pursed lips. So bear with me, see if you can do this with me. What I want you guys to do is to open your mouth as wide as you can and try and breathe in and out for me. So great, I can see some people doing it. That's fantastic. Keep going in and out. Lovely. Now what I want you to do is to close your mouth, and this time when you're exhaling, I want you to exhale through really pursed lips. So try that for me. What you'll find is what we're getting is that the end of breath pressure, so that peak pressure is happening, and you can really control how much air you're expelling at that point. Whereas when your mouth's wide open, you're not so much in control of that. And what people with emphysema are looking for is that feedback. They're trying to force the air out of the lower part of their respiratory system. So quite often they'll do that through pursed lips. And to do that when you arrive, Look to see how they're breathing, look to see if they're pursing those lips, and again ask those questions, is this normal for them? Because you might find that actually, especially in end stage COPD, that patients will be doing this all the time. Other times it's just when they've exerted themselves, and that can be something like walking upstairs, it could be something like going to the toilet, sort of things that we would consider to be everyday tasks that actually that causes them to be quite short of breath. So it's that real difference between sort of that real pursed lips and finding that pressure at the end of their breath. Because there's not the narrowing of the bronchioles and there's not that excess mucus, you usually don't find that they don't have a productive cough. So if you're with an emphysema patient who now has a productive cough, that's usually a sign that something's changed. But on the day-to-day, because it's the alveoli that are affected, you'd have to find that they don't tend to have that productive cough. They're also usually very thin. The reason being is the diaphragm will tend to flatten and weaken. And what will happen is they'll then be using other accessory muscles to try and breathe. So they'll be using the intercostal muscles, they'll be using neck muscles, shoulder muscles. You can see from the picture there, the chap's got his shoulders raised, and they'll be using lots of these muscles just for everyday breathing. So they're really working hard to breathe. And that, therefore, they're burning quite a lot of energy just to breathe. So imagine they're doing things like trying to get shopping, trying to get up and downstairs, trying to do everyday tasks. They're using even more energy, and therefore they do find it very difficult to maintain weight. Also, difficulty in breathing. They then obviously find it difficult to eat sometimes as well. If you're trying to eat when you've got a cold, it's difficult to try and do both, isn't it? So they tend to have a reduced diet and therefore tend to be thinner. Because they are getting oxygen in and they are getting rid of the carbon dioxide, although they're finding it difficult, they tend also to be quite a good colour, so nice and pink, hence the pink puffer, so those pursed lips and the good colour. So again, if you see any cyanosis in a emphysema patient, then we need to be very aware of that. And the picture shows here that kind of barreled chest, and again that goes back to that flattening of the diaphragm, and it goes back to the alveoli not being completely empty. And because the alveoli aren't completely deflated, the chest will always stay slightly inflated, and after a period of time you sometimes get this barreling of a chest. Not always, but do have a look for it. If you're ever looking at a patient with emphysema, do have a good look at that chest and see if you can notice any barreling there. And just a side note, as it says at the bottom there, it is possible to have both chronic bronchitis and emphysema. So, you know, to ask patients if they know their diagnosis and just be aware that they can have both. Lovely. So let's have a look at who gets COPD. So if we look at the facts and figures first, it says here that there's an estimated 1.2 million people in the UK that are living, who are diagnosed with COPD and living with COPD. There's actually estimated there's a further 2 million people who are currently undiagnosed, and that figure is expected to rise as well. So just for people thinking that lots of their symptoms go with age, or that they've been a smoker for years and it's kind of expected that they'll be breathless when they're older and haven't actually been to get that diagnosis. So if we look at the risk factors, the biggest risk factor is smoking. It's a well-known fact. It's, you know, they've changed things like the cigarette packets to have pictures of lungs and lung disease on. You know, they've been big campaigns to get people to quit smoking. Others people have gone to patches, others have gone to vaping or e-cigarettes, that sort of thing, to try and get people to give up smoking, because they're well aware now of the risks involved, and approximately 90% of COPD cases are caused from smoking. Then you've got things like long-term exposure to irritants. So this could be occupational exposure. So if you think about things like mining, so coal, dust, fumes, that sort of thing. Also agricultural, so grains or things like slate or silica. If you think about the communities, mining communities and agricultural communities in Wales is very high. It's likely that we're going to see some of those as well. We can also think of things like air pollution, so that could be outdoor, but also indoor. Lots of people within Wales will have open fires and will be burning wood and coal and breathing in the pollutants from there as well from a young age. There's also genetics. That's less common, but can happen. And if you have a patient who's been diagnosed quite early, so usually if they're under 45, then quite often that's a genetic cause, but again, that's a rare one. And then you have lung development. So this is where you have a mother who smokes when she's pregnant, or children who are exposed to passive smoking or to passive pollutants whilst their lungs are developing and whilst they're growing up. And again, we're more aware of the things like that now. So things like not smoking when children are in the car, which was very common when I was a child, is a big no-no now. And then also thinking about asthma. So if you have asthma, you are at a higher risk of developing COPD when you're older due to the damage of the airways. And then we need to think about COVID. We're living in COVID times. So I've done some research on COVID and how that's affected COPD patients, and actually some studies have found that there is actually a reduction in hospital admissions for exacerbation of COPD during this COVID-19 pandemic compared with pre-COVID times. But I believe that might be due to the reduction in respiratory viral infections. People aren't mixing as much. You know, lots of people have said, oh, usually I've had so many colds per year, and actually I haven't had them because people have been isolating, especially those who are vulnerable have been staying away from people for quite a long time now. So it'll be interesting to see when restrictions hopefully at some point start to lift and ease, how that copes with our new normal, with COVID being part of life now. There are lots of research that's gone into looking at COPD patients though, and their risk if they were to catch COVID-19. So evidence does suggest that those with those with COPD who contract COVID-19 are at increased risk of poor outcomes, including death, and therefore they are considered a high risk group. Research does report COPD patients with COVID-19 have increased odds of hospitalisation, and from that will quite often go on to require ITU admission compared to those with non-COPD. So again, just be thinking about that, thinking about symptoms, but also be thinking about anxiety. You know, lots of people who have been a close contact, for example, and have COPD, or have been shielded for quite a long time, and now then start to develop some symptoms beyond their normal symptoms, can be quite anxious that it's possibly COVID, and they're aware that they're a high risk group. So signs and symptoms. So we're looking at the acute exacerbation of COPD. So acute meaning short term or new, and exacerbation meaning worsening of symptoms. So things we're going to be looking out for. We know from the previous slides how patients might present on a normal day, so do ask those questions, ask what's normal for them. But what you might see is things like difficulty in breathing and an increased respiratory rate. So when we've been looking at the CPD sessions, we've been saying how important it is to make sure we're taking respiratory rates for patients, make sure we're getting really good at those. Do time breathing, do make sure we're just not looking at people and thinking it's about whatever. Actually make sure you're timing those breathings and getting a really accurate respiratory rate, and ask if that's normal for them. Another sign is difficulty speaking. So somebody who can't complete a sentence is a really big sign. And again, ask what's normal for them. Some patients won't be able to complete a sentence normally. Others will be fine normally, but are now really struggling. So do try and get them to speak to you if you can, and see how they're speaking. It might be that actually you need to have long conversations with other family members or carers. But if you can, try and get them to speak so you can see how they're doing there. Thinking also about things like noisy breathing or wheezing or gasping. Some patients, the front door will be open and you'll hear them as you go in. I'm sure we've all heard that in the past. Others will be when you're right next to them and you're listening to them talking and breathing, and you can hear that wheeze in between. And others, even if you're really up close, you won't be able to hear. So do have a good listen. Don't be afraid, as we said before, to ask them things like radios, televisions to be turned off, so you can have a really good listen. Then thinking about anxiousness, confusion, restlessness or exhaustion. So anxiousness is really important because we need to be thinking, are they anxious because they're hypoxic, they've got low oxygen levels to the brain, and actually that's what's causing their anxiousness, or actually is it, as we said before, that they've been shielding for a long time, they're now really worried. If you think back to the last time, if you've ever had an episode where you've been short of breath or couldn't catch your breath, it's really worrying, it's really scary. So try and give some reassurance. It's really important to give reassurance, and see if that helps at all. If it's things like confusion or restlessness, again, that can be from hypoxia, or is that normal for them? Ask what their normal state is like. Ask, if there's any dementia involvement, anything that's unusual, because quite often we've never been to these patients before. We don't know them. The people are with them tend to know them very well and give you some clues into what's normal for them. And then looking for signs of exhaustion. So are they at the stage now where they've been really short of breath for quite a while now, and actually they're really struggling and we need to be stepping in. Increased cough and changes in sputum. So we've mentioned this before, asking if sputum production is normal for them. If it is, what colour is it normally? And if there's been any change. So we're thinking about things like if sputum has turned green or yellow, or if it's bloody. What's the consistency like? I always say that anything comes out of a patient, keep it. Sounds disgusting, but keep it for the crew to see. And they might want to take that through to the hospital as well, because they can send that off to labs and they can get quite specific antibiotics if they're needed. So anything that they cough up, do ask to have a look at it and keep that in a tissue and give that to the crew when they arrive. Then tightness in the chest. So asking things about their chest pain, get them to describe it. And rather than saying, is it tight? Is it crushing? Get them to give you the words so that you can get an idea of how they're feeling. So if they're saying, it hurts to breathe, it's tight in my chest, you can be getting a sort of an idea of, is this respiratory, is this musculoskeletal, or is this cardiac? Do I need to be thinking about that? And that whole time, do be thinking about things like differential diagnosis. So is it a cardiac cause? Actually, am I missing something? I know they're a COPD patient and I've gone down that track, but actually, do I need to swing my focus elsewhere and think that actually there's something else going on here? So be thinking about other differentials there as well. And then thinking about that cyanosis. So we mentioned that might be normal for the patient, but ask, is it normal for that, how they normally present? And the JAL calc recommends if you look at somebody's tongue and gums, it's a really good indication of whether or not there's any cyanosis going on. So yeah, don't be afraid to ask someone to open their mouth and have a good look in it. It's a really good way to check airways and things as well. Lovely, so assessment. So as always, we're always going to start with safety. Safety first, safety for yourself, for whoever you're with, for your patient and others on scene. So once it's a dynamic risk assessment, so we're going to be keeping an eye on everything and continually assessing as we go. Of course, we're going to be thinking about consent. Now, this might be in applied consent, such as you say, can I do your SATs, and they hold a finger out, thanks very much. Otherwise, it might be that this is something they've not had done before, or something that's new, or they're confused, and you might need to describe what you're doing. But make sure you gain consent, even if somebody's confused. Make sure you're talking them through what you're doing, and also making sure that once you carry out an observation, that you give them an idea of what the result is. So rather than just doing a SATs, looking and looking away, they might not be aware of what that result means, or whether it's good, whether it's bad. And obviously, think about how we present that result if it's not great, but just be giving them an idea of, okay, your oxygen saturation show me they're a little bit low, we look at them as a percentage, so I'm just going to pop some oxygen on, or that's come back great, that's within normal range, I'm really happy with that. It just gives some people some feedback as to what you're doing, lets them know that you know what you're doing, but also that if something needs to be done, you're going to do it. And history. So they say 80% of a diagnosis is in the history. Now, we're not asking you to go and diagnose people, but we are asking you to try and get that history before the crew arrive. So going through sample, why don't we, in the chat, someone just remind me, what does sample stand for? Check who's still awake. Lovely, they're coming through. Fabulous. Thank you, Terry. So allergies is in there. Yes, absolutely. Medication, signs and symptoms, Stuart. Fabulous. Neil's got signs as well. Lovely. Last meal. Fabulous. Yep. Previous history and events leading. Absolutely fine. Fabulous. Thank you, guys. So quite right. So yeah, signs and symptoms, allergies, medication, previous medical history, last oral intake, and events leading to whatever's happened until while you're there. So if you try and structure your history like that, then you're not going to miss anything. And it'll give you a really good idea of, especially if they've got this this chronic disease already, they're going to be able to give you a history of what's going on there. Fabulous, great, a nice reminder for you all. Thank you to those of you that contributed there. That's fantastic. And then, as always, we're going to be assessing our patients using the C A B C D E approach. So yeah, try if you can and keep it chronological. Try and go through it, because you're then not going to move on until you've corrected an issue. So do check an airway. It's okay for us to think, okay, it's exacerbation of COPD, but actually, if we've got an airway issue, we need to correct that first. Then we move on to breathing, which we'll look at the table underneath, and then our C, D and E. So looking at B, we're going to be looking at that respiratory rate. I mentioned just a moment ago, we're going to be looking to see if our breathing rate is within the normal range, so 12 to 20 breaths per minute. Is it effective breathing? Do we need to help out with that breathing if we're breathing less than 10 or over 30 breaths per minute? Also looking at the depth of breathing. So are they nice deep breaths? Are we shifting enough air? Or actually, are they really shallow breaths? Some patients, you'll need to really have a good look at what's going on with that breathing. The symmetry of the chest, the movement of the chest. So is that chest moving as it should be? Have you got different sides of the chest moving? Is there anything you're concerned about with that chest? So again, don't be afraid to say, I'm going to be looking at your chest, I'm going to be looking at your breathing. Obviously thinking about patient dignity and where we are. So if we're in an office or an outside space, then that might not be great, but you can quite often look to see if there's any asymmetry going on above close as well. And then thinking about cyanosis, so we'll think peripherally and centrally. So you can think about those gums and tongue that I mentioned, but also looking at things like fingernails to see if we've got any blue tinges going on there. When we're doing SATs, if they're a non-COPD patient, I'm sure you'll know we're looking for SATs between 94 to 98%. And then if they're a COPD patient, we're aiming for SATs of 88 to 92. And I popped a little thing of BBC Radio 2 on there because that always reminds me of what SATs are for COPD patients, 88 to 92, BBC Radio 2. Little reminder for everyone. We're going to go through observations. If we can, keep it in the ABCDE approach. That's going to help us calculate our news score when we come to the end as well. So thinking about pulse rates, making sure we take a manual pulse rate. We don't just rely on the one from the SATS probe or the blood pressure monitor. Thinking about capillary refill, thinking about blood pressure. If it's appropriate, we need to take a BM, then we can. If not, then we won't. Thinking about GCS, don't bypass that one because we are looking to see if that patient's confused, if that patient's got a reduced level of GCS, and then thinking about a temperature as well. That's a really good sign. If there's an infection involved, then actually we might see an increase in temperature as well. Just be mindful if a patient's taken things like paracetamol as well, that we might have we might not see temperature if they've taken that. And then listening as well. So obviously we're not asking you to auscultate anybody's chest, but it's just when you're with that patient, what noises can you hear? Can you hear wheezing? Can you hear gasping? Can they complete sentences? And can you hear their cough? And if they are coughing, again, get them to try and keep that so you can have a look at it. Nice job. And remembering a news score. So we're going to be using news to have a look to indicate how well or unwell our patient is, or how well or unwell they're likely to become. So let's have a quick look at a hypoxic drive. So we're looking at why a COPD patient will have a normally reduced SpO2 reading. So within our body, we have chemoreceptors, and what these do is they measure how much carbon dioxide is in our body and also how much oxygen is in our body. And these little chemoreceptors send messages to your brain to tell you what to do about that. So as the picture shows there, if you've got increased CO2, it'll say we need to get rid of this, let's increase our breathing, and we breathe more. Likewise though, if we have increased oxygen levels, it'll say happy days, we've got enough, thanks very much, let's slow that breathing down. So that will continually be monitored throughout our body and send those messages to our brain, which will help control our respiratory rate. With a COPD patient, it's believed that they tend to lose the sensitivity in those chemoreceptors that will register what's going on with their carbon dioxide levels. Because they're constantly living at a higher level of CO2 within their body, basically it gets worn out and it says it's constantly reacting to that. And so what it does is it relies on the O2 levels. So instead of balancing both, it will look at the oxygen levels within the body and decide what needs to happen. Therefore, if we give a patient with COPD too much oxygen, what will happen is what's happening on the right side of that picture. It says we've got lots of oxygen, thanks very much, and it will reduce their respiratory rate. So I hope that makes sense. Therefore, what we're doing is we're looking to keep them in a sort of a state of slight hypoxia. So we're looking for those oxygen saturations between 88 to 92%. That way, what we're not going to do is knock off their respiratory rate. So it's very important that we try and find out what normal saturations are for that patient. We know what we're aiming for, but patients quite often know what's normal for them as well. And they might have an alert card. We'll come on to that in a moment. But it's really important that we try and do our best for that patient to try and not knock off their respiratory rate. So if I come on to that, we'll look at how we treat them. So we're going to use a stepwise approach, as we would with all of our patients. Stepwise approach, if you can, and then when you arrive, the patient doesn't look immediately time critical, try and get a full set of observations before you do any treatment. It will give you a good idea of what's happening with that patient. Obviously, if you get there and they're gasping and they're blue, you're going to be going straight for oxygen and until you can get reliable readings. But if you can, try and get that those first set of observations. It gives you that baseline so you can see if your treatment is helping to improve the patient or not. Then we're thinking about positioning. So it might be that you arrive and the patient will already be in an upright or tripod position. So if you think about a tripod, patients will quite often naturally lean forward. They'll try and take the weight off the front of their chest. If you ever done a long run afterwards, you'll find people will naturally lean forwards and go into that natural tripod position. And the reason being is that people want to try and get as much oxygen in and as much carbon dioxide out, and that's the easiest position to do it in. However, what you'll sometimes find is patients, because of illness or injury or frailty, won't be able to get themselves naturally into that position. The amount of patients I've been to who are really short of breath, and I get them, they're lying flat in bed. And actually, propping them up slightly and bringing them up into a more upright position, their SATs will come up really quickly naturally. So it's really important to think about the patient positioning. Do be mindful, though, of postural hypertension. So it might be that actually your patient's blood pressure won't allow them to be sit fully upright, which is fine. We'll allow for that and we'll get them into a more upright position if we can. And you can also think about raising legs or just propping them with a pillow so they're not completely flat if that's possible. Then we're going to be looking at oxygen levels. So what we're trying to do is to get those O2 levels to 88 to 92%, as we mentioned. So we're going to be administering O2 via the 28% Venturi mask at 4 litres, the JR-Calc's recommendation, just to maintain those oxygen saturations. And if the patient is on home O2 and they're already on that and it's not doing enough, you might move across to our mask. If not, we might use their own mask, but on our oxygen, and that's up to 4 litres to try and maintain those saturations. If, however, their SpO2 is below 88%, we're going to up our literage between 5 and 10 litres per minute via a simple face mask until we get saturations of 88 to 92, and then we'll reduce it and titrate to response. So that's why it's a really good idea to get those that SATs probe on early. However, if your patient's looking very unwell, is blue and is struggling to breathe, and you're struggling to get that SATs monitor on and get that reliable reading, give them O2 until you get a reliable reading, and then you can titrate to response. So if in doubt, give them the O2 until you get that reliable SpO2 reading. And it's really important with these patients that we're going to monitor them and reassess. If we're not monitoring or reassessing, we're not going to know if what we're doing is helping, if it's working, if we need to change things, if we need to change patient positioning again, if we need to up or lower that O2. So just be really mindful of going over and over and making sure we're doing the best for our patient by monitoring and reassessing. Also, we can update control. And this is also a good time that if you're thinking, I'm not sure what to do next, or I'm not sure if this patient's improving, that we can also speak to CSD. Remember, they're always there. There's always somebody on the end of the phone to give you some clinical advice if needed. And then thinking about documentation. So when you're doing your observations, try and get the time. So when you're doing those observations at different intervals, you can see how long it's been for the patient to improve. I know we keep promising you new paperwork coming. It is coming. Please do bear with us. There's been a slight delay at the moment, but we'll wait to find out more and hopefully get that new paperwork out to you so you can record those observations all on one page. But also it allows for a news score as well, which will give you an idea of what's going on with your patient. And I keep mentioning it, a sputum sample, but there it is again. So if you can, keep that. And just be looking for signs of exhaustion, but be prepared for patients to deteriorate. It does happen. And if you're getting a SATS reading, you're thinking, oh, in the 70s, is that right? Perhaps it's not very reliable. Be prepared that actually that might be reliable. We mentioned it in the CPD course of changing the little screen on your SATS probe to be landscape rather than portrait. So you get that nice waveform rather than just the up and down monitor going on. If you've got a really good waveform, it's a good indication that you're getting a reliable reading. So do, if you can, change it to landscape. It will give you a much better idea of what's going on. There's a copy there of an alert card, so do ask patients if they have a diagnosis that they may have an alert card, and it will give them an idea of if they use HOMO2, if they don't, what their normal oxygen saturations are for them, what they aim for, and we'll give you some advice on that. So if they've got one, do ask for it. Also think about rescue packs. So you can ask if a patient has a rescue pack. So if they have medication at home, quite often they'll have steroids that they can start at home. Ask those questions. Have they got those? Have they started them? Sometimes you'll find they have started them, but it's been less than sort of 24 hours. So actually you're not seeing the effects yet, but do ask those questions, and also any other medication they've taken for it. Do be mindful, though, of the oxygen guidelines and the critical illness and COPD list. You should carry those in your bag, so if you can refer back to those, you're not expected to remember it. But any critical illness such as cardiac arrest, carbon monoxide poisoning, major trauma, anaphylaxis, drowning, convulsions and shock, those patients will receive high flow O2 regardless of their COPD status. If you then start to see a drop off, which is again why we're monitoring and reassessing patients, if you see a worsening of their respiratory rate, we can then drop it down and titrate to response. But otherwise, if they're in that critical list, they do receive high flow O2 regardless of their COPD status. Also, just a note on the bottom there, the patients who are over 50, who are long-term smokers with a history of breathlessness of no known cause, the bit being no known cause, should be treated as having COPD. So it might be that they're not diagnosed yet. We mentioned those 2 million people out there who are suspected to have it but haven't been for a diagnosis. We can treat those patients as having COPD, and of course we'll advise the crew when they arrive that they don't have the diagnosis, but given their age and that history of breathlessness and smoking. References. So if anyone is interested in where I got my information from, there is a reference list. It will go out to you guys again on your training website page, that if you wanted to look anything up, please feel free. Does anybody have any questions? Fabulous. I'm aware I've chucked lots of information at you, but as I said, all of the slides and the recording will be available to you. If you think of any questions now and you want to stay on, then please feel free and we can have a chat. If you think of any questions at a later date, please feel free to drop me an email, nick.anderson@wales.nhs.uk. But otherwise, thank you so much for joining me, and I hope you found this evening helpful.